there's a lot of questions on the test from hyper and hypothyroidism. Remember we talked about that the thyroid gland is controlled by the hypothalamus, and I put this up on the board yesterday because this is just anatomy. But you need to understand this so that you can understand what's going on in the thyroid gland, with the thyroid gland. The hypothalamus controls the thyroid gland, and the hypothalamus releases TRH, which is thyroid protein releasing hormone, and that stimulates the anterior pituitary to release thyroid stimulating hormone, which then stimulates the thyroid gland to release T3 and T4. And T3 and T4 are your thyroid hormones. You need those thyroid hormones for growth and development. You need them for metabolism, carbs and proteins and fats and all that. And so your thyroid gland is very important for metabolism. If your T3 and T4 is too low, your metabolism is going to slow. If it's too high, your metabolism is going to speed up. And that's what you see in hypo and hyperthyroidism. Okay? So with hyperthyroidism, you've got too much thyroid hormone, too much T3 and T4, and your metabolism increases. Oh, I forgot my clicker. Let me go get it. So the symptoms you're going to see with hyperthyroidism is related to the metabolism being speeded up, and we talked about these yesterday. You're going to have an increased heart rate, increased stroke volume, cardiac output is going to be increased, your blood pressure is going to be increased. We talked about the fact that they're very hungry and they're eating constantly, but they're breaking down protein and they go into negative nitrogen, they're losing weight. These people are warm all the time. They're not cold, they're warm because their metabolism is so speeded up. They have hyperglycemia. Part of that is due to the insulin resistance that they have. And part of it is due to the stimulation of the sympathetic nervous system. Let's see. We talked about menstrual problems. We talked about increased libido. These people will have diarrhea, whereas your hypothyroid person is going to have constipation. They're sweaty. They have palpitations and chest pain. Remember the exophthalmos that we talked about, the bulging eyes? And that's because of the periorbital edema. And we talked about you need to protect those eyes because they can get corneal ulcers, dry eyes. Fatigue, muscle weakness, insomnia. They have trouble sleeping because they're so restless and irritable. These people may have a goiter. Their thyroid may be enlarged. And you're also going to see that in hypothyroidism. So when I say that, when we get to hypothyroidism, don't think that's a mistake because it's not. If you take your stethoscope and listen to their thyroid gland, you're going to hear bruise because of all the blood going through the thyroid gland. Okay? Dysrhythmias. Everything's hyperactive. Their deep tendon reflexes, their skin's warm and moist, and their hair becomes fine and silky and soft. And remember we talked about this is rare in children, but if you see it in a child, it's usually in adolescence, and they usually have accelerated growth, and they have accelerated bone growth. Okay. The one that's most common is Graves' disease, and that's the one we're going to talk about because that's probably what you're going to see on boards. And it's more common in women aged 20 to 40. You also can have what we call a multinodular goiter, where the thyroid gland will have nodules in it. Adenomas, those are adenomas, and you see that more in women after age 50. We also talked about the genetic factor. There is a genetic factor related to thyroid disease. It's more common in some families. Laboratory, and by the way, y'all need to know these. Y'all need to know these. I'm not asking you to tell me the range, but I'm asking you to know for hypothyroidism, what are you going to see as far as up and down, and for hyperthyroidism, what are you going to see as far as up and down? Okay? So with hyperthyroidism, their T3 and T4 are going to be increased. Does that make sense?
Yes.
Mm-hmm. Okay. And their TSH is going to be low because it's going to, the hypothalamus is going to tell the anterior pituitary gland to slow down on the secretion of thyroid-stimulating hormone because they've got so much thyroid hormone already floating around in their bloodstream. With Graves' disease, you're going to see antibodies to TSH. Some other tests that they might do are a thyroid scan, an ultrasound of the thyroid gland, and an EKG. An EKG to look for cardiac symptoms. The thyroid scan we talked about. They give them radioactive iodine. You don't do this test on a pregnant female. Okay, let's talk about our drugs. Okay, these are the two oral medications that are used for hyperthyroidism. One is PTU and the other one is tapazole or methimazole. Both of them will inhibit iodine uptake into the thyroid gland, and you have to have iodine in order to produce T3 and T4. So that's what they do. Both of these will alter the immune system, so you need to teach these patients to stay away from people with colds and people that are sick, stay away from crowds. PTU can cause liver failure, so you need to monitor liver enzymes. Methimazole is harmful to the fetus, so you don't give it to a pregnant woman. It can cause birth defects. Other medications that they give are radioactive iodine, I-131. This is a radioactive medication, so you have to take radiation precautions. These will actually destroy the cells of the thyroid gland, and these patients can be left hypothyroid and have to take replacement therapy for the rest of their life. We talked about how you care for a patient and what kind of information you give the patient afterwards. They do have to take precautions. They shouldn't be around small children. They shouldn't be around pregnant women for about a month or so. They need to, when they use the bathroom, they need to sit the void. They need to flush the commode 3 times. They need to wash their clothes without other clothes, and then run a cycle in the washing machine, clean the washing machine. Those things are in your book, so you can look at those. Lugol solution is one that we use to, we give it to suppress thyroid function, and also we give it before surgery to reduce the vascularity of the thyroid gland, because the thyroid gland is very vascular and they may bleed post-operatively, and so this helps hold down the bleeding. And one of the things that we need to do before they have surgery is slow down all that production of T3 and T4, and that's why they do the Lugol solution. That helps with that too, because it's helping to suppress thyroid function. Lithium is also used some, but not a lot, because it has so many side effects. And then we give the beta adrenergic blocking drugs. Lithium inhibits thyroid hormone release, but as I said, they don't use that a lot because it has bad side effects. The beta-adrenergic blocking drugs help calm some of the cardiovascular symptoms that a patient has with hyperthyroidism, and we need to get those symptoms under control before they have surgery. So think about this. We give them Lugol solution to decrease the vascularity so they won't bleed profusely after surgery. We give them Lugol solution to suppress the production of T3 and T4 so that we've got that under control before surgery. And we also give them the beta-adrenergic blocking drugs to calm the cardiovascular symptoms because they can't go into surgery with all those things going on. Okay. Surgical management, they may do a total thyroidectomy, and that's taking out the entire thyroid gland. If they do that, then the patient has to have thyroid hormone replacement for the rest of their life. They may only have to do what they call a subtotal thyroidectomy, and if they do that, then part of the thyroid gland is left, and that will produce enough hormone so that they don't have to take thyroid replacement.
What did you call that?
Subtotal. Subtotal thyroidectomy. So let's talk about postoperatively, and this is important. We're going to talk about post-op care for the patient that has had the hyperthyroid patient that's had surgery. We're going to monitor the vital signs every 15 minutes and then every 30 minutes once they're stable. Of course, we're going to medicate them for pain. We're going to teach them how to hold their neck and not to put any stress on that suture line. We're going to monitor them closely for hemorrhage. Make sure you look underneath their neck because blood flows downward by gravity. You may see some serous sanguineous drainage, and serous sanguineous drainage is blood tinged. You don't want to see any bright red drainage. That would indicate hemorrhage. One thing you need to think about is, are they bleeding internally? Because if they're bleeding internally, so you need to, that's one of the reasons why you need to monitor their vital signs. If their vital signs are stable, probably they're not bleeding. But if they're bleeding internally, it can compress the trachea, and they can have trouble breathing. So with that said, you need to monitor their respiratory status very closely. You need to also think about laryngeal nerve damage. The laryngeal nerve may possibly have been damaged during surgery. So you need to be checking their voice, the tone of their voice every 2 hours. They may have some hoarseness after surgery. And then a big thing is hypocalcemia. Remember, the parathyroid glands are right behind the thyroid gland, and if they've been damaged or accidentally removed during surgery, because the parathyroid glands play a part in maintaining calcium level, then they can develop hypocalcemia after surgery and develop tetany. And if they develop tetany, you're going to see the twitching around the mouth. Do y'all remember that? Twitching around the mouth, the fingers. Okay. That's a sign of hypocalcemia. You also need to check for the Yost and the Trousseau sign. One of them, I think the Yost sign is where you tap on the face and they twitch. You tap on that facial muscle, and the Trousseau sign is when you put the blood pressure cuff on them and pump it up, and they do the carpopedal spasms. So those are positive for suggestive of hypocalcemia. Let's say that. Let's see what else I need to tell you. Another thing you need to remember about hypocalcemia, I'm sure that Ms. Ward told you all when y'all were talking about electrolytes, is that calcium, potassium, and magnesium are important for cardiac function. And if you have a low calcium level, they can have dysrhythmias, and they can be lethal, and they can die. So that's another reason to monitor for signs and symptoms of hypocalcemia. One of the things I didn't say about the laryngeal nerve damage is also you need to listen for they may have laryngeal stridor, and that's a high-pitched sound when they breathe. So assess for that, along with assessing their voice every 2 hours. What do we give them? What do we give them if their calcium level is low? What do we give them IV?
Calcium carbonate.
Calcium carbonate, yes. Yeah, and they need to be monitored. They need to be on a monitor. They need to be in ICU or CCU if you give them if they're getting this stuff. Okay. The other thing we're going to talk about before we get off of this is thyroid stone. This is a rare complication that can occur after thyroidectomy, but it can be lethal, so we have to talk about it. This has to do, remember I told you that before surgery we try to calm down all that T3 and T4 that's floating around in their blood, so we give them Lugol solution. Well, what can happen is during surgery, because the thyroid gland's been manipulated, then excess amounts of T3 and T4 can be released into the bloodstream, and they can go into what we call thyroid stone. And so it's a excessive hyperthyroidism, a very severe hyperthyroidism. It's life-threatening, and what happens is, remember when I said that the T3 and T4 control the metabolic rate? Well, now they have an exaggerated metabolic rate. And all those symptoms that you thought about as far as hyperthyroidism are exaggerated at this point. So they have an increased metabolic rate. They have a fever of 102 to 106 degrees. I don't know if I said that yesterday. Mm-hmm. They have tachycardia, and they have hypertension, very high blood pressure. Very high blood pressure. And they can have seizures and go into a coma and die. So we have to treat this. And so, of course, the first thing we want to do is maintain a patent airway. And we're going to give, because they have all that T3 and T4 floating around in their blood, we're going to give them antithyroid drugs. Tapazole or PTU, but tapazole is a drug of choice. Methimazole. You need to monitor not only their respiratory system, but their cardiac system. They're going to have an IV going. We're going to give them propranolol IV. Remember I said that they have a very high blood pressure, so we're going to give them propranolol for that. Inderal. Propranolol Inderal. Because their temperature is so high, we're going to put them on a cooling blanket. We've got to get their temperature down, because that temperature, if it gets up to 106, can kill them. Now, we need to give them something for their temperature, but we're not going to give them aspirin, because aspirin brings about the release of one of your, it brings about the release of free thyroid hormone. So you don't want to do that, because it makes their thyroid hormones go up more. So we need to monitor the calcium and the magnesium. This is rare, but when it does occur, it's bad. Okay, nursing care for this patient that's hyperthyroid, it makes sense that we're going to monitor their cardiovascular and their respiratory status, right? Mm-hmm. it makes sense that we're going to monitor their temperature because, and this is any patient with hyperthyroidism. This isn't necessarily your patient that's had surgery. We're going to monitor their temperature because their temperature is high. They're hot. We're going to reduce stimulation because they've already got all those hormones floating around in their bloodstream that's stimulating them. We don't need to stimulate them anymore. So we need a calm, quiet environment. We're going to administer their medications, and if they've had surgery, we're going to do pre- and post-op care. I talked about this yesterday. If they have exophthalmos, we want to monitor. We want to make sure that we're taking care of their eyes because they can develop corneal ulcers. Their eyes are going to be dry. So there's a lot of different things we can do. The doctor may order artificial tears. We can, they can wear dark glasses, eye patches, and we can, y'all looked at me like I was crazy yesterday when I said this, but you really can tape their eyes shut at bedtime. And they may be on short-term steroid therapy to reduce swelling. I don't know if any of you have given corticosteroids in the clinical area, but corticosteroids are anti-inflammatory drugs, and they will decrease the swelling and also help and make them more comfortable, and also diuretics to decrease the edema. And we're also, I didn't have this one up there, but we also want to monitor their nutrition because, remember, they're in negative nitrogen balance. And so we need to weigh them daily, and they need to be on a high carbohydrate, high protein diet. Because they've lost weight, they need to have in-between meal snacks. And they need to avoid coffee, tea, and colas because those are stimulants. So teaching, we want to teach them not only the signs and symptoms of hyperthyroidism, but we also want to teach them the symptoms of hypothyroidism because the medications we have given them and some of the things that we have done to them can make them hypothyroid. So we need to make sure that they understand that they need to have follow-up with the physician. They need to have their thyroid hormones checked. And if the patient's had surgery before they leave, you need to teach them the signs and symptoms of infection. Does that help that we went over it?
Yes.
Good. All right. We've got lots of time, so we've got plenty of time to finish what we need to finish. So let's talk about hypothyroidism. And as we go through this, you're going to see that we have almost the opposite of what we've had with hyperthyroidism. With hypothyroidism, you have a low level of thyroid hormone, and the metabolism this time is decreased. You need iodine in your diet for your thyroid gland to produce and secrete your thyroid hormones. So that could be one reason, and really that's probably the most common reason because there's some parts of the world where there's no iodine in the soil, and so we don't get iodine in our foods. So that's one reason why we buy iodized salt. Okay. I said yesterday that hypothyroidism in an adult is called mixed edema. Hypothyroidism in a child is called cretinism. So let's look at, we went through this yesterday a little bit, so we'll go over it again. One of the symptoms, here are some of your signs and symptoms. One of the symptoms is mixed edema, and that's a mucinous edema they have over the body, and that's really a non-pitting edema. So they have edema, but it's not pitting. When you look at their body, the edema is not pitting. They also, with this mixed edema, will develop a thick tongue. They will develop a husky voice, and that's because of the edema around the larynx. And they can actually go into a coma, what we call a mixed edema coma. This can be life-threatening because the end product of this, or the end result of this, is that they have decreased cardiac output and decreased tissue perfusion. They have a they develop a flabby, enlarged heart. And so because of that, if you think about the heart pumps blood out into the circulatory system, to the tissue level, and if you have a flabby, enlarged heart, then it's weak and it can't pump the blood out. And so their cardiac output is decreased and they have decreased tissue perfusion. This develops from long-standing, untreated hypothyroidism. Okay? So you have to treat it. I had, years ago when I was working critical care, and I still remember this lady coming in with hypothyroidism, and she was a textbook symptom of hypothyroidism. She was not in mixed edema coma, but she had all these other symptoms. So every time I teach this, I think about her. You have to treat this. They have difficulty breathing. Why do you think they have difficulty breathing? Probably because of the edema, and do you also think that it might be because of the decreased tissue perfusion? They're not getting oxygenation to the tissue level, and the blood's having trouble getting back to the lungs to be oxygenated, right? Mm-hmm. So they have difficulty breathing, so you have to monitor their respiratory status. So you need to maintain a patent airway with these folks. We're going to put them on IV fluids. What do you think we're going to give them as far as medication? What do they need? What drug?
Diuretic.
But this time we're going to give it IV. We're going to give levothyroxine, and the trade name is Synthroid, and we're going to give it IV. We're going to give corticosteroids if the physician prescribes it, and the corticosteroids will help with the inflammation and edema. It won't actually get rid of the fluid, but it'll help with the inflammation that all that edema has caused. We're going to put them on a warming blanket because their body temperature is low. Does that make sense with hypothyroidism? Their body temperature is low, so we're going to put them on a warming blanket. We're going to monitor their vital signs, their temperature, their blood pressure. These patients have bradycardia. So we're going to monitor, the heart is affected, as I said earlier. And we're going to monitor their mental status because they have mental status changes. And we're going to put them on aspiration precautions also.
What's that?
Aspiration precautions is when they get something down into their lungs.
Oh, okay, like the aspirin.
We don't want them to aspirate. So, with this patient, some of the most important things we're going to do is we're going to make sure that their airway is patent, monitor their respiratory status, monitor their cardiac status. We're going to put them on a warming blanket, aspiration precautions, monitor their vital signs. When you are thinking about nursing care for your patients, think about the signs and symptoms that you're seeing, and that will lead you to your nursing care. Okay, some other symptoms. With hypothyroidism, you also see menstrual problems in the females with decreased fertility, impotence and infertility in men. Coarse features. I think that's the thing that I remember the most about this lady that I had in critical care years ago that had severe hypothyroidism, the coarse features. Edema around the eyes. We talked about bradycardia. Their respiratory rate is going to be slow, their blood pressure is going to be decreased, but they can still have dysrhythmias.
What's coarse features?
I think about the skin being coarse when you touch it, and rough. decreased body temperature. These folks are going to gain weight because their metabolism is decreased. Are you seeing the difference?
Yes.
Yes. And these also may have a goiter. Now, when I was looking at this, I don't know why I didn't see this, because I always look at my notes 2 or 3 times before I teach. I don't know how I didn't see this, but do you see their etiology treatment for hyperthyroidism in the U.S., thyroid surgery, radioactive iodine? Mark through that. I think a gremlin got in there and put that there. But the etiology worldwide is lack of iodine. Because remember I told you iodine, you need iodine in order for the thyroid gland to produce and secrete T3 and T4. As far as the prevalence, you see this more in women between the ages of 30 to 60. It seems that thyroid problems are more prevalent in women. Have you noticed that? Mm-hmm. So, here's your laboratory. When you look at lab results for this patient who has hypothyroidism, their T3 and T4 are going to be decreased, but their TSH is going to be high in primary hypothyroidism, and that's what we're talking about. We're talking about primary hypothyroidism. Remember, secondary is outside of the thyroid gland. With primary, the problem is within the thyroid gland.
Like, my fiance has Hashimoto's.
Mm-hmm.
So the thyroid problem is secondary.
I would have to look up Hashimoto's. I know that Hashimoto's is a cause of hypothyroidism, and I'm not sure whether it's secondary or whether it's primary. What does he do? Does he take?
They actually have not to be weird, but it attacked the thyroid, but it attacked the test.
It's an autoimmune disease.
So they are doing an HCG replacement that they said would help the thyroid too. They explained it and said that the whole endocrine system is like one big circle. Mm-hmm. So if you treat the part that was most affected, then it should put everything back in. Mm-hmm. But I don't know. He hasn't went back for blood work in a while.
The little bit that I remember about Hashimoto's is I think it's an autoimmune disease. And have they given him any medication yet?
HCG injections 3 times a week.
Okay.
But they didn't give him any thyroid medication.
Okay. So they think it's outside the thyroid, I believe.
Yeah. Mm-hmm. But his T3 and T4 decreased, and his TSH was really high.
Okay.
But they didn't give him any thyroid medication.
Okay.
They just gave him the other. They were going to give him testosterone, but they said that would make him 100% infertile.
Oh, really?
I guess if you give a male testosterone, then it kills the sperm production. That's what the endocrinologist said. I don't know.
I'm not sure of that. I don't know.
Dane's over there like, I'm not going to take any testosterone.
Bodybuilders take testosterone before going.
I don't know.
But I thought they had problems.
They said they have problems.
I hope they don't get pregnant at all.
No,
Well,
but
you know,
like,
their count's down.
You know what I mean?
typically.
I've always
Their
heard,
significant other.
Yeah, I've always heard like the bodybuilders, they have, or their
I've
wives
heard that
are
too.
normal.
Yeah,
Yeah,
that must be why.
steroids. That's what I'm
That's not
thinking.
testosterone replacement.
Yeah, no, steroids are not.
Steroids is not.
Yeah, that's totally different. That's totally different.
I don't know. They said that the testosterone treatment would be more effective, but if he wanted a chance at having children, not to take it, to do the HCG.
That's interesting. Okay. I'll have to look at testosterone.
Maybe
and see
just
what
the way
it
it
says.
interacts.
Yeah. Okay, so for what we're talking about, we're going to the T3 and T4 are decreased and the TSH is high. Okay. All right. So here's your treatment. Levothyroxine, Synthroid. And this is lifelong. Because if your thyroid gland if you're hypothyroid, you're going to have to take thyroid replacement for the rest of your life. So let me tell you some things about levothyroxine. So First of all, we start them on a low dose, and the dose is gradually increased until an effective dose is reached. Because if you start them on a high dose, you could get, you could throw them into hyperthyroidism. So they start on a low dose, and then gradually increase the dose until they reach a point where they reach a happy medium, the metabolism is working well, and they're doing well. So levothyroxine increases the metabolism. And it promotes the production of glucose in the liver.